G'day, welcome to today's Triple T TV show. I'm Ted Jedinak. Don't worry, it's not contagious. But contagions, I got this rock star here for you. I'm going to introduce this man to you in just a moment. But first, let me introduce myself. I help foot fixers take their skills to the next level so that you can shortcut your path to the leading edge of your profession. I've been a health practitioner now for over 30 years and had the great privilege of training foot fixers globally for over 22 years. If you're a physio, chiro, osteopath or a podiatrist or a physical therapist, then welcome, you're in the right place. Thanks for joining us live on Triple T TV. That's Ted's Tips on Tuesday. And today, got a really exciting show for you because I've lassoed this man into the program today. Great friend and all-round great guy, Ben Corso. Ben, how are you on this very fine Adelaide sunshine day?
TJ, very happy to be here and very well. So thanks for inviting me.
It's indeed my pleasure. Oh yeah, okay, so TJ and BC, this is how we typically refer to each other. So if you're wondering if you want to buy a vowel or something like that, they may not be up for offer. Okay. Look, one of the reasons I've asked Ben to join us on Triple T is because every time we catch up for a coffee or a lunch or a glass of wine, he's always got some fascinating insights into the latest research, clinical experiences. And I always think, whoa, the FMT family would love to hear this stuff. So here he is. And have you noticed you haven't heard much so far? Because that's probably because
I can't get a word in.
Yeah, we'll see if we can make a change for that. Okay, today's topic is drugs versus exercise therapies. And this is for arthritis in particular, osteoarthritis. Our subtitle is "The Evidence is Hard to Swallow." Get it? Drugs. Okay, yeah, all right. You're going to leave today's show with clear action steps to improve your clinical outcomes for your osteoarthritis patients and the evidence that supports them too. So, first arthritis question I have for you, BC, and that is, why can't you find any aspirin in the jungle?
Tell me. Haven't thought about that one.
Because the paracetamol. Paracetamol. Okay, well, we've got to thank you. A nice thumbs up there. Yes, let's move right along, shall we? We've got a fabulous show lined up for you today, chock full of valuable references. Look at all this stuff that Ben's done in preparation. We'll be telling you all about these at the end, so please stay tuned. Today's show is for health practitioners who feel that they could or would like to offer effective treatment options for patients suffering from osteoarthritis in their lower limbs. Now, if you've already got your OA patients totally taken care of and you aren't interested in evidence-informed treatment options, look, you may as well go check the rest of your Facebook feed because there may not be much in store for you. But before we kick on, let's just quickly recap what happened in last week's show. Did you watch last week's Triple T show?
I think you filled me on all the details. I didn't need to watch it.
No, you didn't. I reckon I probably gave you 16 replays of what really happened rather than what actually happened. Okay, so last week we announced our workshops for 2018, both of them. Yep, there's just two, happening in Auckland and Adelaide. And we've had an amazing response to all the workshops, especially the new knee workshop that Ben, BC, the man here himself, will be facilitating. And this leads me right into my introduction because I reckon I've done enough talking, wouldn't you say? Oh yeah, I thought so too. So, Ben and I actually met. I'll give you some introduction. We met, it was over 10 years ago. We were just clarifying, 2007 was a momentous year for me personally. And we had been, I'd been a patient of yours. I rang the Physio Association, said, who have you got there that's half decent with golf injuries, being a mad golfer at that stage? And so they gave me a list of names, but they said, if you want to try someone else, then there's Ben. So that's how we first met. We celebrated my 50th birthday together in Rome, and that was, I was going to lie about my age, but no, that was in 2012. And in 2018 in months to come. It looks like we're going to have some fun together in Milan with good friend and physical therapist Dr. Simone Scaglione. So look out, Milan, here we come. So Ben, let you get a word in edgewise. Please tell our FMT family about yourself. When did you graduate?
Are you sure I'm allowed to talk? I better make sure before I start talking.
I'm going to have a drink because I have been told I could talk underwater, but instead of doing this, right now I'm talking underwater. No, okay.
So TJ,
yes.
So I graduated in 1995, which always frightens me when people ask me that question because it makes me realise how long I've been doing this job, and it probably also reveals my age somewhat as well. But yes, 1995. Why did I do physio? Well, to be perfectly honest, I completely fell into it by mistake. I had no idea what I wanted to do in terms of a career. But you had an interest in art and architecture. I had an interest in art and architecture and design, of course, because that was my family background.
Yes.
And my parents were both in that world, and my siblings have subsequently, some of them have gone down that path.
Okay.
So I guess I thought I was always destined to work somewhere in that field.
Mm-hmm.
And I did Year 12 art and really enjoyed that and did quite well at that. So much to my art teacher's disgust, I then went and became a physio, which they never forgave me for.
There's got to be a lot of art in physiotherapy.
It's a good question because in the end we had a neighbour who was a physio, and I got talking to her a couple of doors down about physio, and one thing led to another, and I got my results and thought I might give this a go. And so it was
you got enough points to get into physiotherapy?
I got enough points to get into physio. Now, whether I would now or not is another question. But yes, it was very much by accident, and I had a bit of information about the physio world from this neighbour. I had, an interest in activity and sport and health, and I perhaps just put the two together and thought, well, maybe I could give this a go.
All right.
So... yes, it all sort of started, like I said, not like a lot of other people who have a mad, passionate desire to become a physiotherapist or a health practitioner.
Yes.
And all of a sudden, there I am in the first year thinking, what have I done here now? Yep. This feels like Year 12 all over again.
Really? Because of the challenging nature of the study?
Absolutely. Okay. It's a highly demanding course. Back then, there were a lot of things to cover in a very short time, and certainly the beginning of a physiotherapy degree, it was very theoretically based. So you were doing a lot of reading and a lot of assignments, and sort of started to wonder, when are the patients going to show up?
Yes, I reckon that would be real track.
So in terms of how that all came about, that was the story. But in terms of how it relates to art, well, again, I've sort of thought about this over the years and sort of thought, well, I guess art is about creativity. Creativity is a big component of it. And in the job that we have, we've got to be incredibly creative in terms of the things that we do.
Physiotherapy is a science-based discipline, isn't it?
It is, but there's a bit of an art and science element to it, I think, in terms of not just the knowledge that you have, but actually more, and probably what we're going to discuss a bit today, is the way you impart that knowledge and how you use creative thinking or skills to get the message across to certain people about what it is that they need to do or how they need to do it.
Yes.
So that's the conclusion I've come to.
Okay. Now, we'll fast forward 43 years, because that's how long you've been in practice.
Thank you,
for it.
TJ. Thank you for sharing
so
that with
everyone. You have a number of sites, the physio clinic.
Yep.
A bit of product placement we should have here, shouldn't we?
No, I've got the logo.
Oh, here we go. Yes. Convenient. So you've got 4 sites?
Yes. So we've got, from our inception 15 years ago, it is actually this month.
Oh, happy anniversary.
15 years ago. So we started with myself in one room and no admin person for the first 3 months of its life. To now we have 4 locations.
Yes.
We visit 5 private hospitals. We've got about 20 staff altogether, including a good dozen practitioners.
Oh, end of year Christmas party must be a bit of a wild thing.
It's a big day and a big night. But yes, it's sort of grown, I guess, exponentially, which has been pleasing.
Yes.
it certainly hasn't been without its challenges and its bumps along the way.
Are you talking about challenging patients like me? Is that what you're getting at?
Absolutely, but I'm not seeing you anymore, so I made that one an easy exit.
Nice. Handball.
But yes, it's when you actually sit back and reflect, we're certainly proud of what we've achieved and where we've got to, but that's not to say we're sitting back and resting on laurels and just expecting it's all going to keep going well.
Far
You've got
from
to keep
it.
working on it.
Indeed, and I think that's one of the relevant things I mentioned earlier about how, Ben, you keep on top of the research, the conferences. I know your clinical roles right now are less than what they were in the early days. But what you do to keep up with the latest evidence is phenomenal. And it's not all hard work, though, let me tell you, because you deal with golfing royalty. Yeah. I've got to ask, I've seen pictures of you with Greg Norman, Adam Scott, Rory McIlroy. Was this at Madame Tussauds, or they look pretty realistic to me?
Well, sort of yes and no. That's a very good question. So, no, they were real. The circumstances that they were taken were variable, let's put it that way. Right. But yes, I have always I've always had an interest in golf.
Yes.
As a player and as a sport and a recreation. And then I think very early on in my physio career, I sort of thought, well, how can I perhaps bring these two things together?
Yes.
And always had this interest with golf and physiotherapy and how the two combined and what was out there and what was relevant. So fast forward to, I did a master's in 2002.
Yes. Yep.
And at the end of that, I then set up one of my first practices within a golf club.
Ah, okay.
And so that was the inspiration to then look into treating golfers and combining physiotherapy work with golfers.
Yes.
And then that from there has evolved into looking in certain areas in that field. So we've had some experience dealing with the 3D technology in terms of how to analyse a golf swing.
Yep.
And it also led me down the path of being fortunate enough to do some work with the Australasian PGA and the medical team, and so I've been able to work at many of the events in Australasia over the last sort of 5 to 6 years.
Yes.
And of course, as part of that work, you get to rub shoulders with these sorts of people.
Yes.
And I mean, the work is very good. It's very challenging.
Yes.
But it's also very enlightening to work in environments like that and see players come and go and move from one place to the other, and how they prepare and what they do that contributes to the lives that they lead and the sport they play. Yeah,
it's incredible. Do they still ask about me?
I think I've had to refer to you a few times in relation to the foot and FMT, but haven't had any responses lately.
Yeah, right. Okay, it might be time for us to progress forward. Also, your life partner, Michelle, your wife, also a physio. How the heck does that work in the household?
Yeah, look, it's a good question. There are a lot of physio couples out there, and of course many met in the process of studying physiotherapy. But
as students, that's how you met?
As students.
Okay.
Look, I guess we have gone down different paths in the profession, and that's one of the great things about the profession itself, is that there are a number of different areas that you can explore in terms of your career.
Yes.
Different areas you can work in, different forms of work, whether it be clinical or research or teaching. And so she's very much gone down the neurological pathway and with her research and teaching and her work itself. And so her world in physiotherapy is a little different to my world.
Yes.
Although there is certainly overlap with people that we see and the problems that they come to us with. So, so I think having a couple of young children at home means that you don't have time to talk about physiotherapy matters too much.
Yes, I can well imagine. All right, now we've got a fair bit of discussion and things to talk about today, particularly in relation to some of the medical treatments involving orthopedic surgeons, drug prescription. How did you get involved with the Orthopods? Because you're well regarded in the orthopedic community.
So, look, I think going back to what we were discussing earlier about physiotherapy, one of the things I really enjoyed when I started doing the course was anatomy. And that's something I had never had any real exposure to. Hadn't studied anything like that at school or what have you. But the anatomy really got me interested. And then my very first job was as a new graduate physiotherapist in a major public hospital here in Adelaide doing a rotation. And so I got to work in the orthopedic department very early on in my career. And it's probably where some of that knowledge gained as a student I could almost implement or affect straight away, because having a knowledge base of anatomy and then looking at some of the orthopedic work that was done and looking at fractures and looking at where things were put into people, you could identify with that, I think, a lot further. So that's probably what really gave me my interest in the orthopedic side of things.
Okay.
And then again, I was fortunate at that time to work with a lot of the trainee orthopedic doctors and registrars at that time, who then also went on to become consultants and work in the private world, which is the world that I ended up working in.
Yes.
And so really it was, again, a bit of an evolution of I've started working in that environment and followed those relationships all the way through.
Almost sounds a little serendipitous, of meeting the right people at the right time.
Absolutely, and the orthopedic community have been very good to me and to our practice. So I guess we spend a lot of our time nowadays trying to give back, and we give back in terms of education, trying to do education sessions with the orthopods. Obviously referring to the various people that work with us as well, and those relationships have to continue to be worked on, and you need to keep building new ones as well. So that's been, I guess, a focus of our practice.
Indeed, and certainly knowing how you and your business and your team operate, there's no question you've got that wired up. I think maybe I could learn something from that. But anyway, for those of you who've just joined us, I'm Ted Jedinak, special guest, manipulative physiotherapist here, Ben Corso, physio to the golfing stars, among others, and we're here reaching out to the global community of foot and leg fixers so that together we can join forces to take our skills and expertise to the next level. Together, I mean, you're used to, for those of you who've seen this program before, brought to you by Teducation, because it's like education from Ted. But with Ben here, we've come up with a new title of Beducation.
So would that mean that people can lie down while they're listening to us?
There's an idea there. Or maybe we can show them our top tips in bed. I think
maybe for another time.
That'll have to be one of those R-rated programs. Anyway, all right. So today we'll give you 50 plus years of clinical experience. That's you and me put together. Well, I've got about 40 of them, so that's always, yes. All right, so what we're also going to be doing is drawing on some of the, most astute minds on the planet. And so to find more clinical solutions for this beastly problem of osteoarthritis. Today's topic we're going to sink our teeth into is drugs versus exercise therapies. The evidence is hard to swallow. You're going to leave today's show with the best evidence-based treatment options for osteoarthritis for the lower limb. What? Sorry. Ben was just kicking me under the table there because not evidence-based. We're not going to be giving evidence-based stuff. What are we going to be giving?
Well, there'll be an element that is evidence-based. I think the term that tends to be used more so these days, or what I've heard more researchers and clinicians talk about, is actually more evidence-informed information. So
what's the difference?
Really the difference is that with respect to evidence-based research, obviously that is research that clearly shows definitively that a treatment or a management program either works or it doesn't, or it has a strong effect size or a weak effect size. And obviously that is important to know, that we need to be aware of what it is out there that has some definitive findings.
Yep.
But in terms of evidence and form, well, we know as clinicians and therapists that there are a range of things that we do for our patients where we do get good results. And just because the evidence might not clearly identify that they work or they don't, doesn't necessarily mean we should throw the baby out with the bathwater, so to speak.
All right.
So evidence formed is probably a more appropriate term, because it tells the public, if you like, that you're seeing a clinician that is aware of all the evidence that's out there for a particular topic, whatever that might be. In this case, we're talking about osteoarthritis. and is able to be informed by that evidence to make clinical decisions for the best outcome for them. And so I think there is an important distinction between saying, right, well, you can only do this because this is what evidence-based shows.
Yes.
Well, actually, yes, I can take that and I can use that and I can still implement what I know will get good outcomes or good results.
See, I told you, he makes so much sense. It's like a simple word, informed versus based. That's new for me. I'm absolutely going to be applying that. When I remember, you're kicking me again.
Sorry,
what have I done?
Sorry. You're talking too much.
Again, all right. So, with saying that osteoarthritis is a significant condition affecting a substantial portion of people, how many people are affected by osteoarthritis?
Well, the data in most civilisations, most countries, including Australia, is that certainly in Australia alone, it's over 1 million people are suffering osteoarthritis. Right. So when we have a population of whatever it is, 22 million at the moment, is that about right? Yeah, it's a significant portion of the population that are suffering the condition. And the data in Europe and the UK is pretty consistent with that. And obviously they're dealing with much larger populations.
Yes.
But, it's still up in the order of, 10% of the population or more in some countries. So it is a huge problem and significant sort of chronic disease that we see, day after day in our practice.
Yes.
And I suppose being so common, it is therefore something that I've really been interested in terms of how we're actually managing this condition and what are the best treatments and what is the best approach, probably more so.
Yes,
rather
because
than
we can't cure joint degeneration, can we?
No, well, no, not according to the literature. And there's a lot of myths that are propagated about this particular condition. And that is one thing that often comes up is, can we cure it and can we reverse it? Right. And I guess that comes down to a lot of the current medical research looking into those sorts of things. But as physiotherapists, speaking as a physiotherapist, we probably, I would like to think, we try and steer away from talking about cure and reversing an active process. So it certainly can change. I guess our language is more about how we can teach people to manage this best. What are the best strategies for them to manage it so that their quality of life, their levels of pain, etc., are not at the point where it has a significant impact on their day-to-day.
Yeah, okay, well, that makes sense. But, I've, as a clinician, and podiatrists will be able to relate to this, where you might be doing a general treatment. It might be corns, calluses, or some other guzzy stuff, and people will say, I've got a touch of arthritis, or I've got significant arthritis. What's the difference between a touch of arthritis and severe arthritis?
Well, look, it's a great question. I mean, it depends how you define that.
Well, how would you define that?
The reality is that most people over a certain age start to develop arthritic changes in their joints.
Yes.
And that's a normal process. It's not necessarily a pathological process from my understanding of the literature. And I guess the second thing that goes with that is that if you take X-ray imaging of people and you look at their joints, well, again, a significant proportion of those may show some arthritic changes, but may be totally asymptomatic.
Okay.
So it really depends on how you're defining it. Are you defining it based on what someone's been told? Oh, I've got a little bit of arthritis, or what they believe they have?
Yes.
Are you defining it on, have I had an X-ray and what does that show?
Yes.
But what we do know about the radiology is it does not necessarily correlate with clinical symptoms. So you could have somebody with relatively minor arthritic changes on a radiology scan or an X-ray that has significant symptoms, and quite the opposite is true. And I've seen lots of patients like this over the years where they might have a horrible looking knee or hip on X-ray, but actually clinically and functionally be performing quite well.
Right.
So I guess the question then becomes is what is the source of their symptoms or their dysfunction? Is Is it purely the arthritic process, or are there other factors?
Yes, and this is, I know the global foot fixing family will certainly identify with that for those patients who have come in with plantar heel pain. But I got x-rays and I got a heel spur.
Yeah.
Same thing, where they can be totally unrelated. Okay, so effective OA treatments or management strategies. Like today's topic is the exercise therapies versus drugs. What's going on here? Why is this a topic of interest to us as practitioners, clinicians?
Well, I think there's obviously a lot of literature out there now that it talks about this very topic, and some of it I know we've shared with people that are watching this. But essentially, the OA treatments throughout most of the literature is broken down into pharmacological treatments, so drugs, non-pharmacological, and physiotherapy gets lumped into that basket, and surgical. That they seem to be the three key areas where people look for treatment options for arthritis. I guess where I became interested directly is that what seems to be recommended, certainly if we're talking about the non-pharmacological world, what seems to be highly recommended as important and beneficial strategies for patients to manage this condition, again, specifically talking about hip and knee arthritis, is not actually necessarily what is happening in the clinical practice world. So even though this evidence sits there and is fairly definitive in terms of the research that's been published, it doesn't actually mean that that's what we're seeing.
Hang on a second. We've got to dive into this. So you're saying that even though the evidence is there in clinic, like, have you got an idea of half the people not applying this clinically, or is it an arbitrary?
Again, if you look at the papers that are talking about, again, just talking about Australia now, but the papers that talk about things like referral patterns of GPs for this sort of condition, as an example, you will find that a very small portion of patients are referred for allied health input, including physiotherapy and podiatry input, relative to the number that are referred for pharmacological-based treatment.
What do you mean small number? Are we talking
well,
like 30%,
we're
40%?
We're talking less than 10% overall.
Oh, okay.
And certainly if you look more specifically at diagnostic groups, it's still less than 20%. So even though we have a fairly strong weight of evidence that to manage certainly hip and knee OA, that things like exercise and weight reduction for those that are overweight are the cornerstone of the non-pharmacological treatments, very few patients seem to be actually taking that up as a treatment option, versus the ones that are either being referred for an x-ray with the issues that we've just discussed, or recommended to take medication, which is at the other end of the scale. We're talking 60% or more seem to take medication for this condition, versus the ones that are doing some sort of active program. And there's still a high level of referral for surgical intervention. Now, surgery is obviously very effective. I guess the question becomes, at what point, though, is it appropriate? And how many people have gone through, if you like, the right pathway before they've made that decision to go down the line of an operation, which is a big thing.
So, can you tell us when, like, how many surgeries, or on a percentage basis, are unnecessary or have been shown to that? Like,
it's very hard to determine whether they were necessary or not, because they've been done. So the surgery has happened.
Yes.
But like I said, we can only go by the data that's reporting on management actions that people take for arthritis, or referral patterns of GPs in Australia. And again, the number that are referred for the conservative non-pharmacological treatments are significantly lower than pharmacological and even surgical referral.
What about dissatisfaction rates with post-surgery? Like, is there any data on that?
There's probably some evidence that looks at people's outcomes. What we know is that certainly with surgery for hips and knees, people get very good outcomes, and there's some great procedures that are being done and developed that people are getting even better outcomes. with respect to pain. But what we do know is that 12 months down the track after hip and knee replacement, there's still a high proportion of patients that report still functional limitations.
Oh, okay.
Now that's
a
not
high proportion. What's that?
We're talking between 15 to 30%.
Okay.
Of those that have a joint replacement. Now, that's not to say that there's anything wrong with their joint replacement. Their joint replacement's probably functioning very well.
Yes.
But what probably hasn't happened is they've either not continued with their rehabilitation program, or they've not returned to levels of activity that they otherwise could have returned to. And that might be through just lack of knowledge, lack of advice that, yes, it's okay, Ted, to go up and down a set of stairs after you have a knee replacement. That's quite a safe thing to do, and your knee replacement will be fine with you doing that. But I think in clinical practice what we see is that patients have the operation, get a great result in terms of pain, get back to walking and those sorts of things very early, and then probably prematurely stop their rehabilitation program. And they perhaps don't follow it all the way through until they've actually achieved their goals or reached the things that they, I guess, consider important, and they consider to be important to them.
Which does start raising a whole other set of questions with, how do you educate, or do you have to motivate patients to keep on with their rehab? Because I think we've talked previously, they might have to do that for 6 or 12 months.
Well, absolutely. I mean, I think it all starts with education from the beginning, that patients are informed up front, what their... Let's say they're not going to have surgery, but in terms of a conservative program, what a minimum time frame expectation should be. And there's been some very good research done in Melbourne looking at time frames for knee arthritis and number of visits, and we're talking about in the order of at least 12 sessions and at least 3 months is the minimum to undertake a program to get some good results in terms of pain and function. But then there's further evidence to say that people should really maintain that. They should probably touch base with their local physiotherapist, maybe on a monthly or a 3-monthly or a 6-monthly basis. Why don't people have regular check-up reviews like they would for a lot of other medical conditions? That this actually may be important for them to undertake.
That's not a standard thing? No,
unfortunately, there's probably scenarios where therapists perhaps are a little bit concerned about over-servicing, or they're a little bit concerned about am I going beyond the scope of what this patient needs? They've returned to their function, they should be fine. But the problem with that is we know that the adherence to these programs will drop off over time. So we know these programs are effective, we know they get good results, but we know people don't adhere to them over time, and thereby having someone in their corner. So I describe it to my patients, it's like, I'm the guy in the corner of the boxing ring, wetting you down with your towel and your sponge, and giving you a drink of water in between rounds. And that's the way you've got to look at it. That you've got someone in your corner who's just constantly nudging you to essentially maintain a program, if that's what we want to call it. That's maintaining a good health outcome for them. I don't think that's unreasonable. I certainly don't think it's over-servicing. In fact, what we would consider to be the best evidence-informed practice we have for a condition like that.
Good. And I know I can speak from personal experience that having been in my corner, it's certainly felt like I've gone a few rounds with Mike Tyson after you've dug your elbows and thumbs into parts of my body that...
And I think I'd preface that by saying we're not obviously trying to create a codependency or a dependency. Because our focus is still on teaching and educating people and giving them strategies to self-manage. That is still the focus. So this follow-up we're talking about is not regular in the sense that people are coming back every week, but having a little boost or a top-up session may be effective.
And then modifying their exercise or their rehab.
Keeping it fresh, keeping it new, keeping them on track.
Okay, so you mentioned that that's evidence informed. That whole 6-12 months even, it sounds like that's not an unusual reality of what it takes for a joint replacement, knee replacement, that type of thing.
Not at all. I mean, we see that in young sports people that have a knee reconstruction. We know it takes them that long.
Sure.
So why should it be any different, really, for somebody who's arguably more elderly and having a significant operation? A hip or a knee replacement is a big operation to have. So it wouldn't be unreasonable that they would have some ongoing input to again get the best outcome from that operation.
Yeah, obviously what they're going to be doing afterwards is not elite sports force levels or anything like that.
No.
But for what's important to them, huh?
Yeah. So as I said, there's good research showing that people do still have functional limitations, and there's also good evidence that they don't necessarily return to an increased level of activity. Now, when I read that surprised me, and I sort of thought, why would you have a hip or knee replacement if your plan was not to increase your level of activity afterwards?
Yes.
Not to do more walking, do more gardening, play more golf. The evidence doesn't support that. So there's got to be some underlying reasons why. And again, my clinical experience would tell me that one issue is that, yes, they give up on their rehab too quickly. They don't follow it through long enough. Perhaps the education about what is safe for them to return to in terms of activities and sports and what have you, perhaps isn't reinforced enough. Okay. And maybe people aren't encouraged enough to do things that they otherwise think might be unsafe. And again, there's a good paper looking at knee replacements on this topic. And what they found was that if you look at stair mobility, so people's ability to go up and down a set of stairs, what influenced their ability to do that after a knee replacement was not their range of motion necessarily, or their pain, or their strength, but it was actually their belief that they could actually do a set of stairs. So their belief that it was safe and they were able to do stairs was the most predictive factor of their ability to do stairs.
Get out.
Which again just raises questions about, how are we managing patients and are allied health practitioners getting the best results? And if they're not, maybe it's the belief of the practitioner. Not just the belief of the patient, but maybe it's the belief of the practitioner that governs the outcome. So if the practitioner doesn't think that doing 12 weeks of exercise is going to make any difference for that arthritic knee, maybe it won't.
So is there any evidence that actually shows the beliefs of practitioners and the influence of clinical outcomes?
Yeah, so there's quite a bit now that is coming out in the lower limb and the shoulder research showing that the therapist beliefs in the condition and the outcome strongly influences that of the patients and therefore the outcome. So and I'm sure these are topics we'll talk about down the track, but this brings in issues like the language that we use to describe the condition that we're treating, the language that we use to describe how important exercise is for them, the language we use that tells them that exercising in some circumstances into pain may actually be safe, not unsafe.
Che cosa, come si dici allora 11 oh sorry, I just was thinking about the language that we use.
You've defaulted to your Italian. Are you bored?
No. Look, I've already got 1, 2, 3, 4, 5, 6, 7 references that you've evidence informed or what the literature tells us. Good news is that everything that Ben has been referring to today, we have summarised for you in today's Beducation freebie. Get it? Beducation, Ted and Ben. I think that's a classic anyway.
So you have to look up those references when you're lying in bed.
Yes, exactly. You wouldn't want to do that standing upside down. But there are links here into all of the topics in relation to the arthritis, what should be done to manage it, what the prevalence rates are, how effective different treatments are, and the effectiveness of interventions for osteoarthritis of the knee. Now, the knee is all we understand. It's a big, important joint. For the podiatry foot fixers out there, is there anything that can tell us as far as treatment or observations, connections of the foot to the leg. I know the foot bone's connected to the leg bone, but...
you just used my line. That's what I was going to say.
Phew, that was close. Had to get in quick.
Absolutely. So
you can sing it, though.
Yeah, absolutely. So obviously there's we've known for some time as physiotherapists that if we're treating a knee, that we also need to look at the foot and the hip and the lower back and all those connections.
Yes.
Because obviously one will influence the other. And so from a physiotherapy point of view, we can talk about the knee and we can focus on that, but without addressing some of those other, what we would probably term as potential contributing factors to that knee problem, then we're really not giving the patient the best outcome.
Yes.
Because we're only managing, it might be the pain, but we're not addressing the things that have actually potentially led to that problem in the first place.
Yep.
And so that's where it's really important to have a good thorough assessment of the joints above and below. And if we're talking below, we're talking about the foot and ankle. And this is where working with podiatry colleagues is really important, that you commonly will pick up a knee problem related to something going on in terms of the mechanics of the way they walk or run, or what the foot's doing or not doing, as the case may be. And this is where bringing your podiatry colleagues in to be involved in the patient's management is, again, best practice in my eyes.
So would you, as a physio, have a clinical testing protocol that would try and work out, like, where's the cause coming from? Is it coming from above? Is it coming from below?
Well, basically, there are a number of strategies that we could use to try and determine, well, what's the relative contribution of one thing over the other?
Yeah.
So I'll use a very simple example. If you're dealing with someone with knee pain that you suspect may have a hip issue or a foot and ankle issue, then one strategy related to the foot may be that we may tape their foot and change their foot position, and then assess the effect on their knee, and assess some of our clinical tests on the knee, and determine relatively what contribution we think the foot might be making to this presentation. And vice versa, we might look to address the hip as the first port of call with exercise therapy or manual therapy or whatever it might be, and determine what impact is that having on the knee. My suspicion is that the majority of things that we see in relation to knee pain probably have a component of a bit of everything. And it's the therapist skill, I guess, and their reasoning process that should help them determine, well, where should I spend most of my energy in this presentation, and how do I progress through that?
Okay, makes good sense. And so my question now comes up, well, how do I know? And let's again refer to our podiatry colleagues. How would I know if I'm doing my biomechanical assessment or gait analysis and I've got a patient who's complaining of knee troubles? What would be the physio/physical therapy type of tests? Like, I would think that would be an important thing to know. Look, do you, in your dealings with podiatrists, do you find that there are podiatrists who, I don't know, poach or utilise your type of testing? Do you see the big differences, similarities? I've asked about 3 questions in one there. Sorry.
Look, I guess my experience to date tells me that increasingly there's more podiatrists that are doing more treatments than perhaps has traditionally occurred. And what I mean by that is the patient's perception of a podiatrist 20 years ago, and maybe other allied health practitioners, was you went to the podiatrist to get orthotics.
Okay.
That seemed to be the standard. Okay, that's what a podiatrist does, and so that obviously had its complexities with regard to the patient experience.
Okay.
For example, if they were charged a lot for a set of orthotics and didn't get any benefit, they didn't speak very highly of podiatrists.
Okay. Yep.
Equally, if they went to physios and had a lot of passive therapies and didn't get any good outcomes, they wouldn't speak very highly of physios.
Sure.
So my experience to date, though, tells me that increasingly, as I said, podiatrists are now moving more into physical therapies. You're a great example of that with the work that you've done. But increasingly things like dry needling and exercise, and I think it's important. I think patients expect that now, that you're going to do more than just an assessment and a set of orthotics, that they're expecting that you will intervene in other ways, or you'd at least recommend other types of interventions.
Yes.
So that with the example you've used, if you've got someone who's got knee pain and your assessment as a podiatrist is that the foot is the problem, and you set them up with a set of orthotics or whatever it might be, but they actually have a hip dysfunction, well, my experience would tell me that knee's not going to get any better unless that hip's addressed as well.
Okay, it makes sense.
So I guess it all comes down to your reasoning and also your assessment and reassessment. And that's something that we were very strongly trained in as a young physio in this state, is that your assessment and your reassessment more so.
So reassessment after your intervention?
After your intervention. It might be even after a clinical test. That's something we underestimate. We get the patient in, we do our assessment, and we change all these things even with the assessment.
Yes.
And so perhaps we should be reassessing after that before we even apply an intervention, because we may have already changed the way they have presented just through what we're actually doing as part of the assessment.
Yeah. You're seeing the wealth of experience, education and content this guy has. And this is one of the key reasons why I've said,
very generous.
No, you've got to come and help, particularly with the podiatrists. You've got to help them understand, not only conceptually but clinically, what are the tests they can do and how they can help. And this is why we have got ourselves together in order to put on the clinical training where we can get together and literally, particularly for podiatrists, be able to learn those clinical skills that can help with their assessment of foot and lower limb problems like arthritis. There's a whole gamut of stuff, and look, if you've just joined us, here's my mate Ben Corso, manipulative physiotherapist, physio to the golfing stars, and so far in this show we've reviewed the evidence that compares drugs with exercise therapies, and we've also looked into some of the key factors that influence practitioners' clinical reasoning and their treatment recommendations. There has been literally tons of this research stuff and data, and in particular there was one slide that he said I can't show, which is that one there, because it belongs to someone else. Ben, if you're not exactly sure what specific type of exercise or manual therapy treatment would help your arthritis patients, look, I'm just going to say I'm not sure that podiatrists are trained in exercise therapies for osteoarthritis.
Well, I have to say they've got to come to the workshop.
That was a nice segue there.
So, no, look, it's a good question, because I'm not aware of the lengths and breadths that the podiatry training goes to in these areas.
Yeah.
I know physios absolutely are trained to work in this space, but as are a number of other practitioners now in the allied health world, or the broader health community. So exercise physiologists and personal trainers and what have you that have all got some experience with exercise. I guess where physios have always tried to not so much separate themselves, but have our point of difference, is that we're trying to relate that specific therapy, whether it is exercise or something else, to that clinical presentation. And we know that clinical presentation is very unique to that individual, which is why providing generic programs to a wide range of people is not very effective.
Okay.
But in terms of our training, yes. So the answer is yes, we're trained, but there always is questions that surround things like the parameters of exercise, the dosage, the length of time, the number of times a day. There's a lot of questions that surround, well, how do I actually prescribe this most effectively? And of course, the other one is what exercises?
Yes.
Because we know if we take the knee, there are hundreds of exercises you can do for the knee, but of course, what is relevant and what is most effective? And looking at the OA knee research, I was horrified at how simple some of the exercise therapy interventions were to get great results.
Really?
Some of the most basic things that we've probably done for a long, long time, certainly I was trained in 20 years ago, are still very, very effective. And that may come down to just packaging them the right way and prescribing them correctly and doing them for long enough or often enough to get the good results. And again, I think what we've probably got to do better is making the exercise therapy prescription more specific to whatever the condition is.
Yes.
what the patient themselves is presenting with and what their goals are and what we know from the evidence.
Yes.
It's really putting all of that together. It's not saying, well, I'm going to give you these 5 exercises, Ted, because the EMG study I just read showed that these are the best 5 exercises for the knee.
Uh-huh.
Okay, now that might be great, but that might not suit that individual. It might not fit with their goals, and it may not be appropriate. So we need to be informed by that evidence,
Yes.
as we were discussing earlier, but not necessarily prescribe that in black and white.
Okay, and this is what we're covering in the workshop, huh?
This is what we'll cover in the workshop, absolutely.
I'm excited. All right, so let us look at if you've just joined us, we have had a great session here with manipulative physiotherapy extraordinaire BC, Ben Corso. BC, does that mean you were here before Christ? No, sorry.
May have been in another life.
It also has some Buddhist tendencies. But anyway, today's freebie. This is a freebie. We'll have a list of references that Ben has talked about or referred to today. And also with our upcoming workshops. We've got links down here below so that if you want to get some quality time and quality education with a man who, I was going to say, if there's something about knees and rehab, exercise, prescription and assessment, and you don't know it, it's probably not worth knowing. So before we sign off, let's just check if there are any questions or if you've had any frustrations with dealing with arthritis patients, and particularly it could be patient attitudes or even practitioner attitudes for that moment too. So Tito, great, always extremely informative. Thank you very much. Good to have you joining us here. If there are any other questions or comments, please feel free to add those on. If you have any suggestions of topics or ideas that you would like to hear more about Ben, because I've got him for the next 3 weeks. Or maybe I got him for 3 weeks this week and then
I've
next
agreed
week.
to that, haven't I?
I don't know if you agree, but you see those chains that are leading through.
I'll be sitting in the same position in a week's time.
Yes, you better change your shirt. Next week, though, we are going to dive in head first. That could be a bit scary. We're
not talking about concussion, are we?
No. We'll have to get Michelle to help us out with that. Next week, we will be diving in a little deeper with arthritis, but particularly about how fear, food, and fitness affects your osteoarthritis treatment outcomes. Really? Fear, food, fitness? Well, they all start with F, so I reckon there's going to be a lot of effed up ideas coming through. This will be another evidence-informed show starring this man here, BC. In the next Triple T show, we're going to reveal even more gangbuster tips, tricks, and references. These are all looking at improving your clinical results with your OA patients. You're going to love what we've got in store for you. It's just brilliant, if I do say so myself, but that's because I can count on this guy. Thanks very much for joining us today. Let me know what you think of today's show. In particular, if you think that the idea or the name Beducation should take on and maybe get rid of Ted, then that's probably a very valid suggestion. If you haven't already liked this page for foot mobilisation techniques, then please do so. Also, if you have a colleague who you think would benefit from some of the latest evidence-informed information about treating OA, then share this post with them. Make sure that you join Ben and myself next week for some more Beducation. There's got to be I don't know, I'm a bit worried about what we're going to come up with. Yes, no, okay, right. Big thanks at this stage to Dr. Lil, who's sitting quietly in the background.
Thanks,
She
Dr.
hasn't
Lil.
told us that. Thank you very much. And thank you, BC. It's been an absolute pleasure to have you here. Really look forward to same bat time, same bat channel next week. And remember, you're only one click away from being able to help more people like never before. Catch you next time. Cheers.